Hello, everyone. On behalf of Healthcare Synergy, I would like to welcome you to the educational webinar on home care evolution, episodes, care transitions, and bundles. I am very pleased to have the chance to introduce our speaker, Ken Accardi. Ken Accardi is the founder and CEO of Uncoda. Uncoda provides software for managing non-medical home care and care transitions. Plus, they have a patient monitoring service to help at-risk individuals avoid preventable hospitalizations. Ken has degrees in engineering and computer science and an MBA concentrated in entrepreneurship. Ken started his career at GE Healthcare, where he led global engineering and was promoted to Chief Information Officer. After GE, Ken was part of the leadership team at VarianNet and at TeleAtlas. Since then, he worked with several healthcare startups, including the MedNest, the iHope Network, and iGetBetter. Today, he leads Uncoda and his new startup, Triple Aim Technologies. Ken blogs about home care technology and leadership at www.uncoda.com/blog. So you can go ahead and check that website to get more information. And with no further ado, here is Ken Accardi. Thank you.
Hi, everybody, and welcome. Thank you for attending today. We're going to talk a little bit about really how the payment models for home health are evolving. I'm going to mute myself for a second and clear my throat. Give me 1 second here. Okay, apologize for that. Hopefully I'm going to sound a little bit better now. So I had that wonderful introduction, so thank you for that. And based on that, I really don't need to go through this. But yeah, I guess I have been in the home care industry for a number of years and really focusing on what hopefully all of you are too, really exploiting the opportunity for home care with the best caregivers and our most expensive patients to avoid hospitalizations and really help reform healthcare by keeping people at home. That's what excites me. And so today's webinar is going to talk, as I said, about changing payment models, mostly in home health, and we'll talk also about how home care plays into that equation. And I have some learning objectives here where first we'll talk about what's motivating some of these changes, and then we'll talk about the new models. And where we really want to help you is to prepare your agencies to take advantage of these changes so you could succeed and win. And maybe if you see some of these opportunities and your agency isn't quite well equipped to take advantage of those opportunities, that might inform you strategically as to what you might want to do moving into the future. And then finally, we'll talk about some best practices. We also have a few follow-up webinars that'll dig further into detail onto some of these best practices, and we'll share some information later. So really, the best way I could describe what's happening in the payment models in the home health world are a pendulum swing. And that pendulum swing talks about really home health is seeing reductions in readmissions. They're seeing ratings through the home health. I don't remember the entire acronym, but basically we're surveying home health agencies, based on OASIS and based on surveys and other things to, really see how people are performing, and that's leading to what's called value-based purchasing. We'll talk more about that. And at the same time, there's new payers for home health. So historically, most home health has come from, for people over 65, has come from Medicare and that kind of thing. But now there's new models and new risk sharing that are called bundled payments and accountable care organizations. We'll talk about those. And then we'll also talk about how that really changes the landscape and how home health agencies need to compete for referrals. So, kind of as a little preview of what's to come in this presentation is shown in the tagline at the bottom, that the winning agencies will be those who can really prove that you're preventing avoidable hospitalizations and also doing it at the lowest cost. And this is very different than today's fee-for-service model. Before I go on, I realized that I was supposed to mention that the way that the webinar is set up, I think it's pretty obvious, but everybody that's an attendee is on mute. So if you have a question, please ask it at any time, and there's a question window in your GoToWebinar panel, and you can ask those questions, and we'll address them at the end. And if there's anything that comes up, like you can't hear me or something like that, put that in, and Gia will let me know, and we'll take care of that. So moving on, I actually have 2 slides that I just took screenshots from the CMS website. CMS stands for the Centers for Medicare and Medicaid Services. And so they do a lot of things, including, they're empowered to make the payments for home health, but they really are kind of the standard setter and the price setter for most of the, healthcare services in our country. And so it's a little bit small on the screen, so I've highlighted a few things from their quality statement that are informing where things are going with these payment models. So if you see at the bottom, there's incentives to improve care, there's value-based payments. That has kind of 2 meanings, and I'll talk about both of them. The first meaning is that they want to pay a higher price for organizations that are delivering better care and a lower price for organizations that are delivering not as good care. So that's one part of it as well. The other way that it's applied is there's new payment models that I alluded to a little bit, where they're basically paying a fixed fee for a grouping of services, and that could be either for caring for a population of people at a fixed price per person, or in some cases, for example, starting this year, there's bundled payments for joint replacements like knee and hip replacements that have been rolled out in multiple geographies, and that's a case where they're paying a fixed fee for that whole procedure. We'll talk a little bit more about that later, but those are the 2 meanings of value-based payments. And then in the right hand, what they're really looking for are things like teamwork, coordination of care, population health, so again, addressing bigger populations, and also leveraging the power of health technology. And then this other page from the CMS website is more specifically about what they're calling value-based programs. And here they're just kind of saying that their goals are to get better care for individuals, as well as better population health and lower costs. So those are the goals of the value-based initiatives that we've talked about earlier. We'll talk more in detail about the home health value-based purchasing program, which has gone into effect in 9 states this year, in just a few slides. The next thing I want to talk about is an initiative called the Triple Aim. And this actually came from, I'm in Boston, by the way, it came from a group called the Institute for Healthcare Improvement, who has their offices on the campus of Harvard, not so far from here. And so the IHI actually came up with this idea of the Triple Aim a number of years back. I think it's about 10 years old. But what they're saying is that they're really looking for our health care improvements to be driven around improving the patient experience, reducing costs, and improving population health. So, addressing a large population of people at lower cost and improving the patient experience. I think it's kind of interesting that they said improving patient experience as opposed to improving outcomes, because in some cases, for example, the Triple Aim would say that hospice is a good thing, for example, as compared to end of life in intensive care, because a lot of times with hospice and palliative care, people are able to end their life comfortably and pain-free, as opposed to in a very stressed out and painful sort of way while they're trying to kind of cling to life for more time. And and additionally, kind of hospice and palliative care provide end of life at a much lower cost than intensive care. So it's kind of, I just bring up that example because it kind of shows that they're really focusing on the experience of the patient as opposed to necessarily the outcomes. I mean, end of life is a reality, and that's the case. But I guess going to my earlier bullet, a great other piece of this would be that in post-acute care, I would say that the great majority of people, if not everyone, would much prefer to be in their home rather than in skilled nursing and that kind of thing. So, so that's another example of improving the experience. And then lower cost, we are looking at situations where winners are going to be able to provide successful transitions and recoveries with fewer visits, and also looking at other ways to control costs. So there's different types of interventions that could be done, such as some things with a nurse and some things with an aide and some things with a call center and then other types of outreach. And then population health, as I implied, is that we're really looking to care for more people. So the triple aim has become very, I guess, popular in literature. There's a lot of things that you read in blog articles, and people are motivated by the triple aim, but in a lot of senses it was also one of the key foundations upon which the Affordable Care Act was built. And one of the things that from the media perspective, the Affordable Care Act was really making sure that more, if not all, of our American citizens have health coverage. So, so that's kind of where population health comes from. So enough about the triple aim. And one last thing, just to kind of end the portion of this discussion about what's motivating all these changes, is that there is also an initiative for patients to have more say in what happens in their care. And this, you might say, well, this is from 1999, so it seems old, but there's a lot more attention being focused to it, and it's for some other reasons as well. But basically what happened was that there was a case where somebody was being discharged into, let's say, a more restrictive environment. I don't know the full details, but probably to like skilled nursing, and the person wanted to be at home, and the Supreme Court did rule that patients have the right to be discharged to the least restrictive environment when the care team determines that the community placement is appropriate. And so that's fancy language, but what it really means is that if people want to go home as opposed to a nursing home, that choice is going to get a lot more preference moving forward. And so kind of what happens with all of this is that we're kind of in a situation where for the first time the hospitals and these accountable care organizations are having to pay for the post-acute care out of their own pockets, and things like readmissions are part of that. So so if you look at what they want to do, is they want to have the best possible post-acute care at the lowest cost, and they're now kind of changing their tune from historically kind of a way of saying, well, the safest would be to send this person to skilled nursing, so let's just do that, and Medicare is paying for it anyway, to kind of a mindset that says, well, let's check with the person, and if they want to go home, let's try to make that happen, and let's look for partners that could work with us who can provide care at home that is going to have good outcomes in the sense that we won't have readmissions, we'll have strong recoveries, and we'll have it at lowest cost. So really the motivation and the payments are changing a lot. So with that, we'll jump into payment models present and future. And as I've just implied a minute ago, really up until today, and certainly in past years before some of these initiatives came to bear, the typical thoughts for post-acute care on the part of the hospital would be to either go to skilled nursing or to go to home health. And I have a statistic here that last year 42% of joint replacements were discharged to skilled nursing facilities. But based on these new programs that I'm telling you about today, there's been a prediction that by 2018 this will drop down to 20%. So this is potentially good news for home health, but as I'll talk about in a little bit of time in a few minutes, there's also going to be a push to say, well, if we don't necessarily want to put everybody through a home health episode at these kinds of costs, if we could perhaps discharge them home and have them work directly with some non-medical home care and just a little bit of care. So so really the skilled nursing facility at $400 to $800 per day, they're definitely looking to cut back on that. And even home health, with episodes in these kind of price ranges, is being looked to be cut back upon, combined with that patient choice that I talked about to see if people can go home. So I'm a relatively young and healthy person, but due to a childhood injury, I actually had a joint replacement myself last year. I had a total knee arthroplasty, which is basically a knee replacement. And since I am pretty healthy, I was able to. I had my surgery on a Monday. I went home on Wednesday afternoon, and I had one visit from home health. I didn't have Coumadin, which typically there's a blood thinner. For me, I just had what they called enteric aspirin, and I was healthy. And the nurse was able to say, well, I really don't need to visit with this person anymore. He's going to be fine with his meds. He's young. He's in a household that supports him, and that sort of thing. So they were able to deliver my post-acute care at a very low cost, and I actually was able to get off my medications within 3 weeks and go into, go to a physical therapy center. So really, my total costs were lower. Again, I'm not of Medicare age or or at the age of people who are higher risk, but what they're going to be doing moving into the future is saying, well, how could we get the right mix of people? There's going to be some people who need that skilled nursing, and maybe they don't have somebody at home who could help them, and they are more of a fragile person medically and that kind of thing. But they're really going to kind of say, well, it's great that we could have these Ken Accardis whose post-acute care is going to cost us, let's say, less than $500, to be combined with somebody who might need 20 days in a skilled nursing facility, and they're really going to be pushing to manage costs lower and lower. I took this slide from a great guy. His name is Dr. Josh Luke, and he talks about transitions of care and bundled payments. And what he kind of, I think, put it in living color here, and said that really that a lot of the way things are going to move is that hospitals are going to be viewed as a last resort. Skilled nursing is going to be a second to last resort, and home health, the networks are going to be narrowed. So as I implied a minute ago, even though there's good news with less or fewer patients going to skilled nursing and possibly coming to home health, there are some initiatives to narrow down the network of home health agencies, and I'll talk about that. And in his slide, he actually talks about winners in this being home care, non-medical home care, private duty, and assisted living. So again, I mean, our healthcare synergy audience is mostly a home health audience, and what I do want people to take away is that there are risks. There's opportunity of less skilled nursing, but there's also risks that people are going to be looking for other models that are less expensive. And kind of talking to that point of narrowing down the networks, there is an initiative. It's currently active in 9 states as of this year that's called the Home Health Value-Based Purchasing Program. Now, in the Affordable Care Act, there was actually, I think, something they just called the Value-Based Purchasing Program, which talked about hospitals, and it started measuring hospitals on certain performance criteria, and based on that, hospitals could be getting up to, I believe, 1.5% higher payment rates if they're performing well, and 1.5% lower payment rates if they're not performing well. Well, this home health value-based purchasing program is really going to a much more extreme level. And if we kind of jump to the end of this program, the agencies that do really well are going to be paid 8% more, and the agencies that do not so well are going to be paid 8% less. So in total, it's a 16% swing. So again, I mean, just putting that in perspective, if the same, if 2 agencies today are being paid $100 for some work, then after this program runs its course, the outperforming agency that's really performing high quality would be getting paid $108 for that work, and the low performing agency would be getting paid $92 for that work. So it's really a drastic swing, 16%, in the difference between the winners and the losers in this equation. So, and just to kind of talk about it, it is based on 24 criteria. The majority of those come from OASIS. 5 of them come from the HCAP survey, which is, a survey out to home health patients. And then there's 2 that come from claims data. That's where they get readmissions. And there's 3 new criteria which are self-reported things having to do with vaccines. But basically, they're looking at these 24 criteria, and there's some quite complicated scoring that goes with this. Your score could be either based on how you actually scored compared to benchmarks in your state, and then the other way of being scored is kind of an improvement score. So if you're initially benchmarked and and let's say that you're relatively low on the scale, but you've improved a great deal year over year, you're actually rewarded for that, even if you're not quite up to the standards that people are being measured against. So that's home health value-based purchasing, and it's a real big deal. And even if you're not in one of those 9 states, it's something that you're going to want to start paying attention to now, because the intention of CMS will be to use this as a pilot program and then roll it out across all of certified home health. Okay, I mentioned these new models earlier. One is called accountable care, one's called bundle. So they're similar but different. So accountable care organizations are really modeled after managed care companies like Kaiser Permanente and the Mayo Clinic and the Geisinger system, where you actually have the payer and the provider in the same organization. And some of those, actually all 3 of those organizations that I've mentioned, were also blueprints from which a lot of the Accountable Care Act was formed. And what they've kind of found is that if you have this group that is both paying and providing care, that encourages them to work more collaboratively to find the best care at the lowest cost. So that's what accountable care is. And in the context of home health, as we get more discharges coming from accountable care, the way it works is that each patient in the accountable care organization will have a fixed fee for their care for the year, and some patients will be more expensive and some patients will be less expensive, but ultimately it's really going to drive those organizations to try to provide the best care at the lowest cost to all of the people. And in the case of post-acute care, they're going to try to look for the lowest cost alternative that's going to provide a good outcome. Okay, now bundle payments, this is a different way of packaging payments together for a procedure. So let's go back again to the knee replacement. So there's actually bundle payments and knee replacements are rolled out in many states this year. I don't remember the exact number. But what's happening is that, I believe I saw the bill when I had my knee surgery and everything all in for the hospital and the doctor and, anesthesiology and all those kinds of things was around $15,000. So what the bundle payment model would do is it would actually fix a fee that would be a higher fee than that, but it would include the post-acute care. So, and I'm making this number up, so don't quote me on this, but if it was $15,000 for my procedure, it might be something more like, $18,000 or $19,000 and include the post-acute care. So then again, as I described earlier, the hospital's going to be saying, well, who can provide, the best care that's going to be successful for this person at the lowest cost? And in my case, it was very inexpensive, and that helps them out because in other cases they will have to go to skilled nursing and things like that. Now, another big thing, and this is kind of a precursor to a slide I have coming up, is that as part of the bundled payment, that includes any readmissions. So if the person is rehospitalized after that procedure and it's related to that procedure, so let's say somebody had a complication like some kind of an infection at their wound site or something that caused them to be readmitted for that joint replacement, then the hospital wouldn't be paid anything for that, and that's a big change that I'll explain in a second. So anyway, the key here, as with everything in this presentation, is that it's all about providing the best post-acute care with the best outcome at the lowest cost. And okay, so now let's talk about care transitions. So this has been, care transitions and readmissions have been, a big discussion over the past number of years, and a lot of it is, so let me first explain. I mean, care transition services are designed to help have somebody move successfully from one care location to another, such as from hospital to home. So that's what care transitions are. And there's a program that went into effect in 2013 where hospitals would get penalized for readmission. So it's kind of similar to the home health value-based payment program that I described, where they actually would benchmark different hospitals, and they do look at it based on the demographics of where they are. So it's a slightly complicated formula. But what they would do is they would say, well, if your hospital is having a higher rate of readmissions than other hospitals, then we're going to penalize your Medicare reimbursements on readmissions. So this is what they did. They imposed those penalties, but the program, I think looking in hindsight, might not have worked exactly how they had hoped it would work. So they actually made this big pronouncement and that sort of thing, and it was going to be 1%, then 2%, then 3% of your readmission costs. And by the end of the program, it turned out that most hospitals, I believe in last year, that around 70% of the hospitals received the penalties. It's not like kind of an all or nothing, but they all received 70% received some kind of penalties, and the average penalty that people are paying is around $250 when they get a readmission. But the thing about it is that the average amount of money that the hospital is getting paid for that readmission is, I've seen statistics averaging around $6,000. So it's almost like a slap on the wrist, where they're getting this $250 penalty, but they're still getting paid $6,000 for the readmission. So if they look at it not from a health perspective but from a business perspective, it's not that big a deal. But that kind of, when I kind of move over to the why this matters column, this is a big change with bundled payment and accountable care. So in both of those models, whether it's a bundle or accountable care, the money is coming out of the pocket of the hospital or the care provider. So here today, even with all these readmission penalties, they get $6,000 and it costs them a $250 penalty, no big deal. But with these new payment models, a readmission, again, if the care costs $6,000, it's going to cost them $6,000. So they're really going to be focused on everything they could do to avoid readmissions or rehospitalizations. Now they really care. And so kind of the takeaway for home health and anybody providing post-acute care is that you really need to provide evidence that you are reducing readmission rates. And and again, I guess kind of historically selling home health to hospitals, a lot of it came down to relationships. And so your marketer who is selling to the hospital would go and talk to them and be getting referrals, and really it would be a decision made between that discharge planner and the home health agencies that they have relationships with. But now that there's such a big potential cost to the hospital, it's really going to be a decision made more from people like the chief financial officer and those kind of people, and the decisions aren't going to be made on relationships. They're going to be made on outcomes and reduction of readmissions and cost of care. So again, I kind of repeated this slide from Dr. Josh Luke, and again, I can't emphasize enough that it's going to be all about success at the lowest cost. And so really I've kind of targeted most of today's presentation on certified Medicare home health care, nursing services, and that kind of thing. But as Dr. Luke's presentation or slide here talks about, is that he says winners are going to be in home care and private duty and that kind of thing. So let's talk about that. And I know that a lot of the home health agencies do have home health aides, and some of them do have ongoing private care. But this kind of puts it in perspective that the hospitals are now bearing the risk and the expense for the bundled payments and accountable care. And what they're looking at is non-medical care is providing a lower cost alternative. So if we think about it, when our combination of nurses and therapists come, they're maybe coming once or twice a week. They're there for 45 minutes and that sort of thing, and they're really kind of making sure that medically everything is going well, that the people are taking their medications, that their wounds are healing, and things like that. But they're not really providing care for activities of daily living to those people. It's really not their job. And but again, if we say that the average, let's say, home health episode is somewhere in the $3,000 to $4,000 range, the hospital might be looking and saying, well, this person, they're in pretty good shape, but, or maybe they're not, but they're going to need some, help with their activities of daily living. I mean, they're going to need help, with meal preparation and picking up groceries and, toileting and those kinds of things. And if they could get those services for, something more like $25 an hour as opposed to, $100 an hour for nursing, they're going to be motivated to do so. So there's a big opportunity for non-medical home care, and this year, and actually we are seeing more and more situations where hospitals are reaching out to non-medical home care to partner with them, and vice versa, that the non-medical home care is going and reaching out to the hospitals to to see if they could play a part in that equation. Again, I mean, home health, we have great nurses and that kind of thing, but one of the kind of classic controversies we have is that hospitals have nursing, have nurses as well. So, and they're a little bit arrogant, right? So sometimes they, might be saying, hey, I could go with non-medical home care, and I could just, basically tell that non-medical home care agency that if anything is up, they could call our nurse hotline and our kind of discharge nursing team, and we'll provide the medical care that they need. So, again, as certified home health agencies, many are considering adding non-medical home care in order to compete, and home care is and should be thinking of entering the market because it's a big opportunity that they never had before. Again, I guess one thing I meant to mention on that earlier slide where we talked about discharging to skilled nursing or to home health is that the medical world acknowledges skilled nursing and acknowledges home health as being nurses, as medical people, and in the past they've never acknowledged non-medical home care as being medical people, and they still don't. But now they're kind of answering a different question. They're not answering the question of of is it medical or is it not medical. They're asking the question of what's the best way to transition this person at the lowest cost back into their home environment. So how do we win moving forward? I said we would talk a little bit about some best practices that I'm seeing in the industry. What I kind of am seeing in some of the agencies that are really gearing for the future, and in some cases partnering with insurance companies and accountable care organizations, is that they're kind of changing the way that things are today, where we have a strong delineation between certified home health and non-medical home care, and they're even adding other things like call centers and automation. So basically, organizations are saying, hey, if I have on my staff, I have people who, are nurses and physical and occupational speech therapists and maybe care transition experts who could visit people in hospitals and assess the risk of that person for a readmission, that, that's great. I have those skills, and the visits in the hospital can advise me on, really what level of care I need to put in this person, into this person's recovery. But I also have, non-medical home care people who can assist with activities of daily living, and I have a call center that can, drive behavior change. I have people who can call from the call center and, and call and nag and make sure people are taking their medications and they're treating their wounds and all that kind of thing. And then there's even new technologies for automated phone calls to check in with people and give you a warning if something's wrong with their health and that kind of thing. So people are really looking at kind of building a pyramid like this, where if we kind of move from the top of the pyramid to the bottom, the costs go from higher to lower, right? So an automated phone call out to check on somebody and see how they're feeling, kind of costs pennies, whereas a call center call is a couple dollars. Non-medical visit, again, I mean, from what we pay the caregivers and that kind of thing, is maybe in the $10 to $15, more like a little higher than that when fully burdened. And with skilled nursing or skilled visits of various types, we're looking at really fully burdened costs more in the $100 an hour range. People are kind of saying, well, how could I provide the entire spectrum of services between skilled, non-skilled call center and automation, and kind of blend these things together to provide the best possible care at the lowest cost. And that's what I am seeing people doing. So with that, again, that's kind of all I wanted to present today. We'll check in a second and see what things are, what questions people have, and we'll answer as many of those as we're able to in the remaining time. Again, I kind of told you who I am. One thing that I will kind of add is that, in my company, we do actually provide a phone call-based patient monitoring solution as well as non-medical home care software. And so if you are, let's say, a home health agency and you're working with Healthcare Synergy, then we could supplement what you're doing to kind of maybe if you're mostly in this part of the pyramid, kind of help you bring in some of the other pieces of the pyramid. So that's what we do. And if that's something we can help you with, we'd certainly like to. So with that, I will kind of open my panel here and see if there's any questions that have come in. Okay. So I guess either I'm not looking right or I'm not seeing any questions yet. So I guess what I'll ask you is if you have any questions, why don't you go into your questions panel now and go ahead and ask them, and I'll take them as they come in. All right. So it looks so far, unless people are typing long things, that I'm not seeing them. And maybe Gia, if you're on the line, do you think that that's correct? That I'm seeing that correctly here? Okay. Yeah. It looks like we haven't had any questions come in at this time. Well, I hope that means that I've been pretty clear in what I've described. But if you do have any follow-up questions, you can certainly send them, and we'll take care of them for you. And with no other questions for today, I will just kind of end by saying that we do have 2 follow-on webinars. I should have brought the titles, but I don't have those in front of me. But I believe that those are coming in just 3 weeks from today and 6 weeks from today, and we'll address those. And it looks like I do have a question just came in. 1 second. I'll take that one before we call it a day. Okay. So the first question that I'm able to read here says non-medical care is not covered by Medicare, so these types of care are all private pay, ? Okay, so that's a great question. Yeah, so private care is not part of Medicare reimbursement, but not, again, I guess as of this year, the estimation is that 70% of the post-acute care will be, Medicare payments, that will go to, let's say, skilled nursing and home health, and the 30% will be more in the bundled and accountable care model that opens up the, opens up for things like non-medical home care. So if it's a bundle or if it's accountable care, then the payer, in this case the hospital, gets to choose what kind of care they're going to do. So there's that opportunity. Now the other thing as well is that for people who have the means to be able to pay on their own, it's going to be totally in the hospital's benefit to, ask the person if they say, hey, I want to go home, and they say, well, geez, if you were in a nursing home, you would have, people around you. If you go home, in your condition, we might recommend that you would need some private home care. Is that something you could pay for? And if the person is able to pay for private home care, then, that's a great benefit to the hospital or the accountable care organization because they don't have that. They don't have that cost. So let's see. So I have another question. My little question panel is a little tricky for me to read here. I apologize. It says non-medical. Oh, okay, so it's the same question. So yeah, okay, so great question there. Okay, so with that, I think we're going to wrap up for today. And again, we'll figure out how to let you know exactly when these next 2 webinars that I'll be presenting are. And we'll be digging more into how you could win with these new payment models. So thanks again on behalf of myself, Ken Accardi, and on behalf of Healthcare Synergy. And we look forward to seeing you at a future webinar. Thanks again.